The answer to the question posed by the title is a qualified yes. Current requirements embraced by regulatory bodies, including the FDA in the United States, seek the ultimate goal of assuring the safety and effectiveness of medical devices during short, intermediate, and long-term clinical use. The following remarks focus on the performance of polyethylene in total knee designs. To appreciate the limitations of in vitro laboratory testing, it is important to realize that it is not just design, material, and manufacturing choices which influence outcome, but is inclusive of both patient factors and surgical variables. Soft tissue interruption and repair, component selection and placement all contribute to the in vivo integrity of total knee designs. The limitations of contemporary wear testing standards are that only ideal mounting and loading conditions are simulated, which exclude apparent gait patterns resulting from skeletal deformity, component placement, and limb alignment, as well as inconsistent loading patterns which occur in stop-start motions, extended rest periods, and microseparation. They do not replicate a true in vivo environment, although attempts at temperature control and lubrication through both rings and serum, often inclusive antibiotics, are utilized. They require long testing times, often out to 10 million cycles of load application for multiple specimens that have been preconditioned through accelerated aging, and because of the above, are expensive in their conduct. They also have shown poor clinical correlation, largely because of unpredictable patient and surgical variables which influence retrieval findings. As is appreciated, polyethylene damage observed from knee implant retrievals demonstrates that the determinants of abrasive wear may be characterized by both sliding distance and surface stress distribution, which is visualized in the following graph from Rose and Goldfarb, which describes a nonlinear relationship between increasing contact pressure and resulting polyethylene weight loss due to wear. Traditionally, tibial insert wear is determined through the use of simulators whose both loading and kinematic pathways elicit wear volumes which are representative of anticipated in vivo articulation. In this regard, multi-station servohydraulic and electromechanical implant simulators are employed. As has been indicated, their employ require long-term in vitro evaluation, are costly in their enterprise, and unfortunately do not always align with retrieval patterns. I am sharing with you my early experience in evaluating the meniscal bearing wear volumes required by FDA to establish safety and performance for the first device of this type. To augment these current physical testing standards for knee implant systems, computational stress analysis and kinematic simulation have been developed as advancing evaluative technologies. Ongoing studies reveal that the contact areas and stresses that are associated with polymer insert damage in high flexion knee designs occur during daily activities, which include stair ascent, chair rise, and kneel rise. Clinical evidence of this may be appreciated from the 7-year retrieval of a fixed plateau design which flexed to 115 degrees at the time of discharge. Knee plateau damage is noted in the posterior medial quadrant of this right knee through surface abrasion, cracking, and subsurface delamination. To determine surface and subsurface stresses, finite element models are created by measuring the articular surface of implantable quality parts using laser profilometry. Contact areas and stresses on and within the polymer inserts are calculated and photorealistically imaged. Under a standardized body weight, images for the PFC Sigm rotating platform are displayed and provide an indication of areas where damage caused by contact with the femoral component can occur. It is noted that in spine cam designs, contact generally occurs prior to achieving 90 degrees flexion, and stresses rise rapidly in magnitude. Additionally, it is appreciated that the footprint of the contact stress distributions overlie and influence subsurface stress volumes. They represent a visual inference for the potential of material delamination and cracking, a dominant mechanism of failure in knee retrievals. Where this conventional polyethylene retrieval demonstrates what I would describe as primary and secondary damage patterns. An example of the consequence of poor fit between the femoral component and the proximal surface of a mobile bearing plateau, as predicted by its finite element model, is displayed. The poor proximal fit propagates to the distal interface, creating contact patterns along the edge. The amplifying effect of prescribed kinematics in a laboratory wear simulation specimen can be appreciated in this photograph from Walker of the distal surface of the same design. Comparison indicates that the finite element model is capable of accurately predicting locations of abrasion. The next step we have undertaken is kinematic simulation through the use of a dynamic musculoskeletal modeling system, which offers a constraining soft tissue envelope with active flexor and extensor muscle groups driving activity. The outputs of the software are animations and plots of the kinematic pathway. The resulting animations and plots characterize the motion of the femoral component relative to the tibial insert in comparison to that of the normal knee in a deep knee bend activity. The virtual components are implanted in the knee sim joint space per the manufacturer's surgical procedure. The plot on the left illustrates anterior, which are positive, and posterior, which are negative, translation of the medial and lateral condyles as a function of knee flexion angle. The animation on the right depicts component orientation from a superior view. The reference points contribute to understanding the relative motion of the femoral component for this design. The figure in the upper left visualizes an accumulation of contact areas during the activity cycles of walking gait and deep knee bend derived from kinematic simulation for a Duracon total knee system. The plot in the upper right describes the damage patterns from a series of 17 retrieved tibial inserts of this Duracon design provided by Scott Banks and Melinda Harmon. The progressive darkened areas suggest a commonality of damage locations amongst the retrievals. The lower image is an overlay plot that visualizes the prediction of the knee sim model and closely matches the abrasive wear scar damage observed in the clinical retrievals. At the end of the day, two evolving iterative computational technologies have been described, which currently augment traditional physical wear testing standards accepted by the FDA and other regulatory bodies. The interconnecting of physical testing with these computational technologies assists the design of contemporary total knee devices, assures the quality control of manufactured components, and serves as in vitro predictors of material damage locations which can be compared to device retrievals. In conclusion, the answer to the question posed by the title is that preclinical testing assists in assuring the safety and effectiveness of contemporary knee designs through short, intermediate, and long-term clinical use. Thank you.